Greetings from Dublin, Ireland. My name is Dr. Phil Boyle. I am the founder of the NeoFertility method, co-founder rather, and the co-founder of the Chart NeoFertility app. I'm currently the president of the International Institute for Restorative Reproductive Medicine as well. And I'm happy to share with you some of my clinical experience treating couples with impaired fertility. We'll get straight into it. I'm going to go through two cases of couples with previous failed IVF and how did we manage to treat these people. With restorative reproductive medicine, we use a combination of several medical or surgical treatments that restore optimum reproductive function combined with fertility charting and timed intercourse during the fertile phase for repeated cycles. So that's a simple definition. What's different between this and in vitro fertilization or other fertility clinics? I hope I'll demonstrate that as the presentation progresses. Like any good clinic and good medical practice, we take a careful history and examination for the couple's first visit. So I'm going to outline these principles first, and then I'm going to go through two case presentations. We work very much with the help of a fertility advisor or fertility teacher, and we use a multiple index method for fertility awareness with NeoFertility. We look at mucus, temperature, and urinary hormones. We work with our app available at chartneo.com, and when you download the app, you simply tap in your symptoms to build up a profile of your fertility cycle. You do need instruction to do this well. So phase one, where we assess and prepare. After I see a couple for their first visit, I explain, download the app, come back to me once you have tracked your fertility cycle and obtained the necessary blood tests. This is a typical fertility charting pattern where we can see the combination of bleeding pattern, cervical mucus, temperature rise, and urinary hormones. We use all of these multiple indexes to indicate where is the woman's presumed day of ovulation. We document the days of intercourse. We document what medications is she using throughout the cycle. She can record different symptoms such as period pain or premenstrual symptoms. And then there's notes to document additional information. This component has transformed my ability to treat people really well. I've got about 600 active charts at the moment, and if somebody phones up with a question, I can get their app on my computer in seconds, and I can see their chart in real time, and I've got all this information to advise them quickly, easily, and reliably. A key difference between the approach with NeoFertility and most other ways of assessing fertility is we have a new concept where we assess the quality of ovulation. The standard practice at the moment for most fertility clinics is a blood test is drawn on day 21 of the cycle, and if a certain value is reached, then fertility clinics will say your day 21 progesterone indicates you're ovulating. There is no problem. The question with that blood test is, are you ovulating, yes or no? And it's a very basic and poor assessment of the integrity of the hormones throughout the cycle. What we've done is we pick the day of presumed ovulation with the help of our fertility tracking system. We time the blood test for between 6 or 9 days after ovulation. And our question is, when you ovulate, 7 days later, what is the maximum surge of your hormones? We would insist progesterone should be above 60 nanomoles per liter and estradiol should be above 400 picomoles per liter. If the blood levels are below those values, then it is a poor quality or suboptimal ovulation, which is at risk. That means it's going to be harder to get pregnant or increased risk of miscarriage. This allows us to detect subtle hormone deficiencies that are commonly missed by most other methods. So it's a very important point. The other thing that's fantastic about this is it's one single blood sample taken to measure the two hormones of progesterone and estradiol. It's a very simple hormone assessment. that is of immense value. And I'll hopefully demonstrate that with these cases. So phase 2, we begin that once I have the information and I look at the fertility charting system, I look at their blood test results. I also look at bloods on day 3 of the cycle, the usual bloods on day 3. And we get all this information together, and then we decide, right, what do we need to do to boost and balance your cycle? We implement a multifactorial treatment strategy. So in addition to hormone assessment, we look at diet, we look at nutritional supplements, we look at the male factor, we look at thyroid system dysfunction, a new concept, which is a whole other lecture. We look at clinical endorphin deficiency. I can give you that lecture another time if you wish. Another big new one for us is low DHEA levels, absolutely hugely important. And a new thing we've just started to look at is the role of the sympathetic tone and its impact for fertility. We also look at insulin resistance, clotting abnormalities, the role of low-grade infections, and then immune dysfunction. And we complement that with surgery if and when required. So the difference with our approach is we implement all of these strategies in a systematic, methodical way to restore optimum function to the cycle. But what's completely different is we work with a fertility charting app to verify, first of all, to establish a diagnosis where the problem is, then to verify we've corrected it. And after we've corrected it, then the next phase that's really important, make sure you see she's ovulating by ultrasound. A lot of clinics will just observe the mature follicle and neglect to confirm complete rupture. So always do a follow-up scan to verify rupture. We only do that for 1 or 2 cycles, and then we have the information we need. Finally, we reach phase 3, where we can say everything is good, you're ovulating by ultrasound, you feel good, your fertility pattern looks good, your blood levels are reaching the target range, and you enjoy being together for some of the fertile days. Now it may happen in 1 cycle, it may take 12 cycles, or anywhere in between. But stay the course. Everybody agrees it's normal to take 12 cycles to conceive once everything is corrected. There's no risk to women's health if we restore optimum reproductive function, produce 1 follicle, release 1 egg, then you're not jeopardizing your health by persisting for 12 cycles, and you give the best chance that you may achieve a pregnancy. When we do this, and we've looked at our data on a population basis, it's comparable to doing 3 cycles of IVF is comparable to 12 balanced cycles with restorative reproductive medicine. We outline that at the bottom of our a presentation at the bottom of our page at neofertility.ie if you want to watch that. So I did have 3 cases, but I'm going to present 2 of them to you. The one case that I'm leaving out at the bottom because we don't have so much time, they were 8 years trying to conceive. She was aged 34. She had 5 failed IVF, 3 with her own eggs, 2 with donor eggs. And with our multifactorial restorative approach, we helped her to achieve a successful pregnancy, which she has since delivered, and everything went fine. So I'm just giving you the headlines of that one, but I'm going to present the details of the other 2 cases. But it's just to present to you, to broaden your concepts, that very difficult cases can get success through our program. I think the other 2 may demonstrate some points that I want to make in particular. So I'm just let you know, this is a really good approach, even for extremely difficult cases. So let's focus on case number 1, 39 years old, reduced ovarian reserve, 2 failed cycles of IVF. I have her ID number there so I can access her through my own records when I need to. She presented to us for her first appointment, aged 39, 3 years trying to conceive, low AMH, 2 failed IVF cycles with her own eggs, and she was told, look, this isn't working with your own eggs, you're going to need donor eggs. She had a 30 to 32 day cycle with a 5-day menstrual bleed, previously used hormonal contraception for 6 years. Her blood test result for AMH was 1.57 picomoles per liter in May of 2021. She had a fibroid surgically removed in July of that year, and in August and November that same year, she had 2 stimulated cycles of IVF. The first cycle, they did not get to egg retrieval. The second cycle, they did get egg retrieval, but no embryo transfer. So that December, she was told, if you want to proceed, the next step is donor eggs, which a lot of people, that's a bridge too far. This is a summary overview. So she first wanted to try to conceive in January of 2019, when she was just before she turned 37. It was over 2 years later, she began more serious investigations where they discovered the reduced egg reserve, as well as the fibroids. Her uterine fibroids were surgically removed. She had 2 stimulated cycles with in vitro fertilization, and by December, when she was nearly 40 years old, was given this sad news that donor eggs were the next step. She was taking lots of supplements to try and improve egg quality. These things are good as a short-term strategy for about 4 months, and then you need to take a break, otherwise they become detrimental. Her body mass index was good, a BMI of 21, and her husband's BMI was good as well. And these are a summary of her blood test results, and you can see on the day 3 of her cycle in May of 21. Bear in mind, she came to me in January of 2022, January last year, and her historical estradiol was really unfavorable, quite low. But her FSH levels were still good. They have not yet started to rise despite her low ovarian reserve. Semen analysis had reduced volume of less than 1 mil, 0.6 mil, but what was collected in the sample, the concentration and motility were acceptable. So phase 1, assess and prepare. So I saw her, took her history, and I said, look, for phase 1, we need you to go and track your cycle and get these blood tests for us and start on some preparation treatment. I often prepare couples with an immune modifying strategy. Everybody that I see with reduced egg reserve, I commonly give a trial of low dose naltrexone. And like I say, that is a whole other talk, but this is what I put her on, so you have an idea. You take this at night, every night before you go to bed, and I put her on low dose naltrexone 4.5 milligrams as an immune modifying strategy. Our additional immune modifying strategy is very simple supplements. Most of us are vitamin D deficient, so she's on vitamin D. Omega-3 fish oils. The important thing about the omega-3 is I want the EPA about 700 per day. So make sure you look at the EPA in the omega-3 that you use. I put her on folic acid, and our generic diet is avoid dairy, avoid eggs, avoid sugar. They tend to cause us problems. So with low AMH, avoid dairy, eggs, and sugar. She had fatigue, low mood, and anxiety, and these negative symptoms will commonly dramatically improve once we start on this strategy. So before we started phase 2 to boost her hormones, I wanted to have a look at how did she get on with those medications and what was her fertility pattern like. So her very first cycle, what I'll point out to you very briefly here is she had very poor mucus. It was just a wet feeling, what we call vulvar wetness. She had that for 4 days, no visible discharge that she could lift or stretch, so quite limited mucus. And what's interesting is it was 6 days after presumed ovulation. Her blood test results were, everybody else will tell her, your progesterone is normal, it's fantastic, it's 31 nanomoles, you're ovulating, there is no problem. We know well there's a problem because she's got low egg reserve and she's nearly 40 and she's had 2 unsuccessful rounds at IVF. But the sensitivity of a day 21 test is completely inadequate to identify there's a problem here. But according to our parameters, this is a significant deficiency. Her progesterone should be up at 60. So we would say you've presumed ovulation, you're probably ovulating, but it is suboptimal, and you've got a short, inadequate luteal phase. So even though you have a 28-day cycle, it's only 9 days of a luteal phase with limited mucus and suboptimal hormones. There's plenty here that we need to treat. You can see here, I had already started her on the naltrexone diet and supplements, but wait till you see what it did for her next cycle. The mucus was dramatically better, her peak day comes in earlier, and her blood test results 7 days after presumed ovulation were remarkably improved, still below our target range. And bear in mind, I have not yet commenced any hormone treatment for her. So I had a couple recently who had 7 unsuccessful rounds of IVF. We did diet, naltrexone, supplements, and she got pregnant successfully just with that strategy before she even came back for hormone assessment. If this couple had used the fertile days, I think pregnancy was now possible with those significantly improved hormones. My preference is for people to avoid the fertile time until we also boost the hormones, but this couple never even had a miscarriage before. So they would be free to enjoy the fertile time if they wish. So when they came back, my goal still is, I want your progesterone above 60. It's still suboptimal. But our immune modifying strategy with diet, naltrexone, and supplements had prepared her so that she's now going to respond much better to the treatment. One of the things that I didn't do here is coenzyme Q10 because she was already on it. So it's 4 months on, 4 months off of CoQ10. If she wasn't on coenzyme Q10, I would have added that as well. Another important part for me to improve egg quality is to give DHEA, but when we assessed her DHEA levels, they were normal and she didn't need to take that. If you take it when your DHEA is normal, you get acne and body hair and it won't improve your fertility. So here's the DHEA levels that were normal. Here's her suboptimal progesterone. We also did insulin resistance testing. Perfect. So no issue there. So another thing we did was the IgG food antibody testing, and we confirmed for her that she's getting antibodies to eggs. So, and she's got some antibodies to milk. So avoid milk, eggs, and sugar is just generic. It's pro-inflammatory and you're better to avoid sugar. So she has poor follicle function. She has low ovarian reserve, clinical endorphin deficiency, because she was complaining of low mood and fatigue, and that got better when we put her on the naltrexone, and she's got these food antibodies. In addition, to get optimum ovulation, I put her on 7 tablets of letrozole on day 3 of her cycle with a HCG trigger injection to encourage follicle rupture and luteal phase progesterone. I wanted to monitor the impact by ultrasound follicle tracking scans for 1 cycle, and every month in the mid-luteal phase, let's assess the impact on her progesterone and estradiol. Remember, AMH of 1.5, 2 failed IVF, never got to embryo transfer, and she's nearly 40. So this is her strategy. I put a line through these other things. I didn't think she needed antibiotics. Or she did no insulin resistance, and so I put a line through those. The blue areas are the areas that I treated. So that's a summary again of her treatment that I've already outlined. And her first cycle, we did ultrasound. I put her on 7 tablets of letrozole on day 3, HCG trigger injection on day 11. Again, I can see all of this jumping off her chart very clearly. Beautiful peak day on day 12. And I did ultrasound follicle tracking day 12 and day 17, and she produced 2 follicles that ruptured, and her hormones were consistent with that as well, a little too high. Now, my goal is to avoid twins because it's better to get 1 at a time, but it's not a problem I thought I would have because her AMH was so low. But there you go, 7 letrozole was too much. So the next cycle, I had to reduce her treatment because there's her 2 follicles rupturing by ultrasound. So that's a little bit too high. So I said, look, we're in the zone, enjoy the fertile days and let's see what happens. Next cycle, she's on 4 tablets of letrozole, trigger HCG on day 13, and her bloods are still a little bit high. So she responding beautifully to the treatment. So very pleased with that. Now, at this point, she had just turned 40, but she started with us at age 39. So I still counted as 39 years old because that was age she came to us starting with the process. And positive pregnancy test straight away on her second balanced cycle with optimum hormones. So a positive test is a great thing, but we're always cautious until we see the pregnancy ultrasound. Prior to the ultrasound scan, we can predict 9 times out of 10 on the basis of the blood test results, what are we going to see by ultrasound. So on the day of our positive test, we look at progesterone, estradiol, HCG, beautiful hormones. 1 full week later, I can see progesterone, estradiol, HCG, very acceptable. And 1 week later, again, the bloods are doing very well. So I can tell her, I'm 90% confident you're going to get a good ultrasound. I discourage ultrasound scans at 2 weeks after a positive test, which is 6 weeks and 3 days gestation. It's too early. And you'll see a little heartbeat at that time, and it could be gone a week later. Wait until you're 7.5 weeks, which is what we did. It was 7 weeks and 2 days, beautiful ultrasound, strong heartbeat. So now I can tell her, I'm 95% sure this little one is here to stay. Follow-up scan 3 weeks later, going fantastically well. So we're even more certain at this stage. So in summary, she started with us in January of 22, and she had a beautiful pregnancy scan by June of 22 on her second medicated cycle. So that's what we can potentially do with restorative reproductive medicine. A lot of people complain, oh, it's going to take too long. It's a long, stretched out process. Sometimes it is, but sometimes it can happen very quickly. So she was due to deliver the baby the 24th of January. And would you believe we haven't heard back from her yet? So I've been chasing her up and saying, we'd love to know what happened to the baby. And we don't have that information yet. So we're still waiting for her baby photograph and the details of the delivery, but we hope and pray everything went well. We hope it did, but that is yet to be updated for sure. We followed her until 28 weeks into the pregnancy and her hormones were fantastic. So we're confident it's likely she had a good delivery. And she did the chromosomal studies at the prenatal screening blood test, and those bloods were perfect as well. So we're anticipating a good result. I expect she just had a busy time. Now, I am painfully aware that my time is limited, so I'm just going to cut to the chase very quickly in this. I won't go through the same level of detail for case number 2, but I just want to emphasize a few important points about the second interesting case. She was age 35. She had 2 previous miscarriages, previously did 18 cycles of ovulation induction, followed by 1 failed attempt at in vitro fertilization. So she came for her first visit, and that's the details of her history. And our clinical impression was polycystic ovaries. And most people would, because her cycles are 38 days, and she had a hyperstimulated cycle when she went for IVF. But most people would say, what are you going to do? You're going to do more ovulation induction. She did it for 18 cycles. She's done that. Have some compassion for this girl. Move it on. There's nothing you can do to help. And we would argue there are things that were missed with her previous ovulation induction that we can do better with a restorative approach, a multifactorial restorative approach working with the fertility chart. So I won't go through all the details of everything we did because of a little bit of time pressure. I will give you the summary that 18 cycles of ovulation induction, 3 cycles with letrozole, 8 cycles with clomiphene, 7 cycles of FSH injections, a hyperstimulated IVF cycle. So she started the whole process when she was 33 years old and 3 months and finished it when she was 35 plus 6 months, 2 full years, no success. And then she comes to us. It was also in January of last year, 2022. Male factor was good. The bloods were consistent with polycystic ovaries with a high AMH and LH reading higher than FSH, but quite suboptimal progesterone levels. I don't know what stage of the progesterone curve that was taken, but that's low by anybody's standards, which is probably why she had so much ovulation induction. Most people I see won't get that amount of ovulation induction. So what we found for her, we did her diet and her supplements. I don't think she needed naltrexone. I wanted to test her for insulin resistance. We found the insulin resistance. I gave her insulin sensitizing treatments. I gave her supplements. I added vitamin B12. I usually add that with the glucophage because it's at risk of going low. And our diet for polycystic ovaries is avoid dairy, wheat, and sugar. So we implemented that to begin with. And this is really important because this can help to improve egg quality before we boost and balance our hormones. So this phase 1, diet, supplements, insulin sensitizing medications, do this first for about 2 months before you start to boost and balance the hormones. So phase 2, when we boost and balance the hormones, here's a real interesting chart. She had little or no mucus at all, no vulvar wetness, no visible discharge, and it was a urinary assessment that allowed us to identify an LH surge, and we checked her blood 7 days later. And often with polycystic ovaries, you get near normal progesterone levels, but it still is poor follicle function in this case. So on her second cycle, we still haven't commenced anything like follicle stimulation. It's still the medications I outlined with the insulin sensitizing treatment, but the mucus is starting to appear just a little bit now in tandem with the temperature rise and her LH surge. So it's getting a little bit easier to pick it out. And this is where I see her at review. She's got 2 cycles and I go, right, here's what we're going to do to boost your hormones. I want to put you on 7 tablets of letrozole for 2 days. Because the usual thing we discover is inadequate follicular stimulation. We find they respond better with a low dose of prednisolone if it's PCO, and then we do luteal phase progesterone, monitor the impact by ultrasound and bloods. Again, now our incidence of twins were running at about 2%, but these cases happened to over-respond a little bit, as it turns out. And it turned out also by follicle tracking, she produced 2 follicles, both of them ruptured. We verified that by ultrasound. The mucus was a lot better. And we verified 2 follicles, both of them rupturing. So we overdid it just a little bit. And her hormones were also a little bit high. So 10 letrozole might have been a better starting point. I think I went a little bit heavy-handed. Positive test, very first cycle. Now, 18 cycles of ovulation induction before. We did 2 cycles of getting her metabolism right, 1 cycle of follicular stimulation. Now, potentially we could have a twin pregnancy here. And remember, she had hyperstimulation, which is potentially very bad for a woman's health and well-being. And what we did was completely different with this one. People say, we've done all the ovulation induction already. What are you doing? I say, you didn't implement a multifactorial restorative strategy where you get the metabolism right, as well as the hormones, and as well breaking the stresses that go with this. The verbal advice we give is, today is the day you stop trying to conceive. And what you do is we'll balance your cycle and you enjoy being together for some of the days to allow fertilization to occur. So I'll go to the bottom line with this. We were able to calculate her due date and we looked at her hormones in advance. I was concerned it could be a twin pregnancy. Her bloods were absolutely fantastic, beautiful ultrasound scans at 7.5 and just about 10 weeks. And thankfully they got in touch with us. They had a New Year's Day baby delivered 1st of January and full term healthy baby, and everything went fine. So thank you for your attention. And I wish you all the best with your conference. Bye for now.